Mhm. A very good afternoon, everyone. It is with great honor and pleasure that I welcome you all to this 14th Pediatric TB Eco Clinic in collaboration with the Regional Pediatric Center for Excellence for Tuberculosis. The Eco Clinic is a dynamic platform for case-based clinical discussions and dissemination of knowledge and bringing all experts together across the country for managing tuberculosis among children. On behalf of National Institute of Tuberculosis and Respiratory Diseases, I extend a very warm welcome to our esteemed Deputy Director General TB, Central TB Division, Professor Urvashi B. Singh and her team. I also extend my heartfelt welcome to the directors and representatives from NIRT, NTIs, state TB officers, directors of STDCs, esteemed faculty members from medical colleges, district TB officers, medical officers, pediatric TB specialists, and all healthcare professionals participating in today's session. Now let me introduce the faculty from NITRD. Myself, Dr. Dulika Dhingra, Specialist Peds at NITRD, and I will be moderating today's session. To my left is Dr. Sangeeta Sharma, former Director and Chief in charge of the National Center of Excellence for DRTB and former Director of NITRD. To my extreme left is Dr. Alok Yadav, CMO NFSG, Pediatrician at NITRD. I would now request Dr. Sangeeta Sharma ma'am to please welcome DDT Professor Urvashi B. Singh ma'am. Over to you, ma'am.
So, welcome all to this session, the 14th session of Pediatric TB Eco. We have been running this session every month on the second Tuesday, 2 to 3 p.m. With different centers participating. And now I would like to acknowledge that now we are extending this Pediatric TB Eco Clinic, considering the response which we have got, the encouragement which we have received from none other than the Central TB Division headed by our Deputy Director General and her team. Dr. Urvashi Singh has always been there as a backbone pillar, and also her team at the Central TB Division, Dr. Sanjay Mattu, the Joint Commissioner in charge of the Pediatric TB program component. As I've said, we'll be extending this platform to include others also, especially the peripheral stakeholders, consider response which we have got. So, without wasting time, this session is going to be presented by none other than Dr. Ira Shah. Dr. Bhulika will introduce her formally. So now our director, the present director, she is on leave. So on behalf of Dr. Upasna Agarwal and my team at NITRD, I welcome each one of you. And now I will ask, request, in fact, Dr. DDG ma'am, Dr. Urvashi Singh, to say a few words regarding the pediatric TB Eco. Ma'am, over to you, Dr. Urvashi Singh. Dr. Urvashi?
Good afternoon to you, Dr. Sangeeta, and to all the experts and colleagues who joined us today. The experts, Dr. Bharadwaj has always been a mentor to a lot of us. Thank you, sir, for always being there. And a big thank you to Dr. Sangeeta, who's always, painstakingly conducted this session, bringing up issues which actually bother us for, clinical care, especially for children here. Diagnosis of TB in children, which all of us know is a dilemma because the presentation is different. The diagnosis, of course, the NAT, which gives us a good pickup in adult TB, is not so efficient in children, and we possibly have discussed this earlier why that could be because of the different immune response, possibly poor immune response, or at times the disease not involving parenchyma of the lungs alone, but more often involving the mediastinum, the mediastinal nodes, etc., where the NAT pickup from respiratory samples can be poor. The issues related to extrapulmonary TB in children stem from the basic delays in diagnosis that could happen in pulmonary TB in children. Like I said, the presentation is different. So the topic for today, Dr. Sangeeta, and of course I didn't thank the director NITRD, who has always been, Dr. Sangeeta being one of them, who's now leading the pediatric care department. The extrapulmonary TB basically stems from the pulmonary origin when the pulmonary TB is missed, and today we are discussing a very important topic because we lose, even in adults, we lose about 30% of patients with TB meningitis despite the best care available and the regimen available. Here I want to bring all your attention to whether the regimen we are using for TB meningitis is the right regimen, because as I've alluded to in a few previous pediatric echo clinics, that if we are using the same pulmonary TB regimen in an extrapulmonary site where drug levels may not be reaching, except for the initial period when the blood-brain barrier is not active, beyond the initial period, the drug penetration into the CSF is affected by its lipophilic nature, by the size of the drug that we're using, by several other factors, which again, groups like Dr. Sangeeta's herself, the NIRT group, myself from AIMS have published therapeutic drug monitoring studies where we have shown that extrapulmonary sites may not get the right levels of drugs that we need the ATT to actually reach to have the true effect on the bacteria. Hence, the question whether the regimen that we are using to treat TB meningitis is the right regimen. And let me share with you, I believe nobody like Indian experts to actually question the recommendation of regimen for extrapulmonary TB, especially CNS and TB meningitis. And we are the ones who should be finding this solution, not only in children, but also in adults. The same holds true. With these few words, I'll request you to carry on, Dr. Sangeeta, and we can discuss later. Thank you.
Thank you, Dr. Urvashi, for your kind words of encouragement. They mean a lot to us, and thought-provoking messages which you always give. Over to Dhulika now.
Without any further delay, we would now start today's session. Today's presenting team is the State DRTB Center of Excellence, Vijayawada Hospital for Children, Mumbai, led by Dr. Ira Shah, Professor and Head Pediatric Infectious Diseases. And the case presenter is Dr. Reepa Agarwal, Junior Consultant, Pediatric Infectious Disease Department, Vijayawada Hospital for Children. Over to you, Dr. Reepa, for the case.
Good afternoon, everybody. At the outset, I would like to thank Dr. Ira Shah Madam for giving me this opportunity to be present in this esteemed podium, although it is virtual, and to all my respected seniors and colleagues. Today, we are going to present a peculiar case of CNS TB, and we would like to take you on the journey with this girl and how we have managed this patient. Please share the slides. Yes, so I would begin with the case summary, and then Madam would explain it in a much better way. So a 10 years old girl, second by birth order, born of third degree consanguineous marriage, was brought to our tertiary care children's hospital casualty. Okay, so we have received this patient in the casualty with chief complaints of intermittent fever since 1 month, headache, lethargy, and decreased oral intake since 10 days. She also had constipation since 7 days, and acutely she had not passed urine since the last 12 hours. Okay, she did not have any history of weight loss on inquiry, but she did have a significant history of TB contact. 1 year back, her grandfather had unfortunately died of pulmonary TB within 1 month of diagnosis. And he was started on first line anti-tubercular treatment, but there was no microbiological proof. At that point of time, no family screening was done. So here we have a 10-year-old girl with fever, with headache, lethargy, and some constipation and decreased urine output. Now this child was promptly examined in the casualty. She was irritable, sick looking, disoriented with a GCS of 12 by 15. Widely at that point of time, her heart rate was 70 beats per minute, blood pressure was 118 by 90, diastolic was little on the higher side. She was not tachypnic. Her pulses were well felt, although she did have sunken eyes. On CNS examination, the cranial nerves were normal, but she had altered speech and she had meningeal signs positive. She had normal tone and power in all 4 limbs, but had bilateral ankle clonus. And on anthropometry here, we are seeing that her weight was 22 kgs, which falls in the 3rd to 10th centile, and height was 144 centimeter, which was 75th to 90th centile. Okay, so here, with this background of a child who is sick looking with a GCS of only 12 by 15, who's having positive neurological signs, that is, meningeal signs were positive, there was altered speech and bilateral ankle clonus. She was shifted to PICU. The first line investigations which were sent at casualty itself included a hemograms, ESR, electrolyte, CRP, HIV. Now CBC did not show us anything very significant. ESR was high, it was 70. At that point, the electrolytes were normal, CRP was on the higher side, and HIV was non-reactive. Next slide, please. Yeah. So here with this kind of a patient where we know that the child is worsening and is having signs of raised ICP, the first thing which was started was for supportive measures for the raised ICP. At that point of time, we had differentials in mind because this was a subacute to chronic onset. Although the fever was there for 1 month, the headache, lethargy were 10 days old. So with this in mind, the child was actually started on IV ceftriaxone at that point of time, and TB was also kept in mind. And for the supportive measures of raised ICP, 3% NaCl was started. Now, to delineate what we were dealing with, urgent neuroimaging was done. Now here I would like to draw your attention towards this tuberculoma, this ring enhancing lesion which we are seeing in the cerebellum. Here I have just shown one picture, but there were actually multiple small ring enhancing lesions scattered in bilateral cerebral and cerebellar hemispheres. And there was associated nodular leptomeningeal enhancement also seen. So the meningeal signs which we were getting was because there was tubercular meningitis present and there was also tuberculoma present. So whenever we have TBM and tuberculomas, we also look at the ventricles. Here we are seeing the ventricles were only prominent. It was not that, the child had developed hydrocephalus. Neither there were any infarcts present. So with this baseline, next slide please. A chest X-ray was also ordered because we know that whenever there is a suspicion of extrapulmonary TB, X-ray is the first thing which needs to be done. And X-ray, I would like, yes, I would like the audience, if they would like to interact and put their comments on the chat box, that what are their observations in this chest X-ray film?
Audience can put their responses in the chat box and we can discuss them later.
Rifa, go ahead.
Yeah. Can you just tap on the slide, please? Yes, so what we're seeing is mediastinal widening and there is miliary pattern of the parenchyma. Next slide, please. So now we know that this is probable miliary TB with CNS involvement. DL was sent, which did not show MTB detected in the CBNAT. So now the question which came to our minds was, should we start anti-tubercular treatment empirically? We don't have a microbiological proof, but we have clinical as well as radiological signs and symptoms which are favoring towards TB, and should we give steroids? Next slide, please. Subsequently, an ultrasound was also done, which also showed mild hepatomegaly and even involvement of the right kidney with focal right nephritis, which was showing development of a granuloma. Okay, so still we are in this probable stage. We don't have a microbiology. Next slide, please. So it is always important to hunt for microbiological proof. Before doing a CSF, a fundus needs to be done to rule out any papilledema. Once this was ruled out, CSF was, a lumbar puncture was done. And this is the report of the CSF routine microscopy. It showed high proteins, 264. Sugar was 44 with the HGT of 120. WBCs were 98, which were lymphopredominant. We could get CSF expert MTB RIF done immediately, which showed MTB complex, which was low, and RIF resistance was detected. We are very fortunate that we also have the XDR expert cartridge in our hospital. So we could also run this sample on that, and that detected INH as well as fluoroquinolone resistance. The urine gene expert was negative for MT. Next slide, please. Yeah, so just a reminder that we have multiple sample specimens which can be sent to detect TB. As much as possible, we must try to have a microbiological proof. Otherwise, this child probably would have started on first line AKT and would have worsened. But here, this child could be started on second line AKT with proper sensitivity reports. And if nothing is possible, which happens multiple times, it is always essential to go back to history and explore the history of contact in details. In pediatric patients, we know that they get TB most commonly from their contacts. Next slide, please. So here we now could confidently diagnose with microbiology in hand, a pre-XDR miliary TB with involvement of the CNS and right kidney, with raised ICP, with dehydration. The child was not in shock or respiratory distress and did not have any dyselectridemia at that point of time. Next slide, please. So during the PICU stay, as I had already mentioned, this child was started on second-line anti-TB treatment. So we formed a regimen comprising of 6 drugs: bedaquiline, delaminate, linezolid, cycloserine, clofazimine, and ethionamide. We also gave the child steroids, which is an anti-inflammatory, at the dose of 0.15 mkdo QID. For the raised ICT, 3% NaCl was started and even acetazolamide was started. Although this child did not have any seizures, but because this child had tuberculomas and there is a chance of seizure, anti-seizure medicine, that is levetiracetam, was added. Aspirin was added to prevent vascular complications. Slowly her sensorium improved. The 3% NaCl was tapered and even stopped. She did not require any ventilatory support in the PICU and was shifted to ward after 48 hours. Till this point of time, everything was going smoothly and everybody was quite happy. Next slide, please. However, when she was shifted to our ward, we have a TB isolation ward. In next 48 hours, what we saw was there was again worsening of sensorium. Initially, this worsening of sensorium was related to her hyponatremia. I will be dealing with that in details in the next slide, which we were optimizing. But subsequently, she developed dysphagia and dysarthria, where she was unable to swallow. And her cough had also become very weak. She also had tachycardia, hypertension, poor peripheral pulses, cold extremities, and loss of gag reflex. So what she had was a fluid responsive shock, which was managed. Her hypertonic saline infusion was also restarted because there is raised ICT features. Here there is a point of caution which I would like to highlight is that in raised ICP, the BP may not fall and shock can be missed. It's very important that clinically at bedside, we try to gauge the patient as a whole. Next slide, please. Yeah. First of all, I would like everybody to think that why did she worsen? She was on sensitive drugs and she is now worsening. She was better, 48 hours, she was in the PICU, she came back to the ward and now again she is worsening. What could be the reasons? Okay, so to understand, one needs to understand the pathophysiology of CNS TB, and Madam will take that up in details. Here, one is there was hyponatremia which happened here because of the CNS TB. Next slide, please. Yeah. So here, what we have to understand is this girl on 29th of May. So this is this we discharged her this Saturday. Her sodium had gone down to 126 and her potassium was 3.2. Here we have to understand that whenever there is hyponatremia in a child who is having CNS and pulmonary involvement, there are two differentials mainly. If the child is not having extra sodium losses like dehydration, vomiting, it is either cerebral salt wasting or it is syndrome of inappropriate secretion of ADH hormone, which is dilutional hyponatremia. And a bedside way of diagnosing it is checking your input and output. Now, this child did not have polyuria. So it was more like dilutional hyponatremia or SIADH. So because it is dilutional hyponatremia, the management comprises of restriction of the IV fluids. So 70% fluid restriction was given, and for this potassium, oral potassium supplement was added. Okay. Now, if you will see that her sodium had started increasing on our restriction. Okay. But this is the point of time when she also developed dysarthria and dysphagia, and hence a neuroimaging was done. And at that point of time only she was having those fluid responsive shock-like features. So of course the de-restriction was done and she was added 3% NaCl. Next slide, please. Okay, so as we were discussing, there was hyponatremia present, which was getting optimized, but still this child was developing neurological signs. Okay, so an urgent repeat neuroimaging was done. Now, this is the previous image which I have already shown you. And in this image, what we are seeing is that the ventricles have really dilated, okay, and there is even periventricular ooze present. So this patient, she had unfortunately now developed hydrocephalus even on acetazolamide. Okay? She had, this is her disease per se, which is worsened. And these are the tuberculomas which were already present. So the radiologist had reported it as interval increase in hydrocephalus with periventricular ooze and increase in the leptomeningeal enhancement. Now the brainstem was normal, although the gag reflex was not there and had become weak, but the brainstem was normal in imaging. Next slide, please. Yeah. So with that hydrocephalus, which is having periventricular ooze and patient is symptomatic, we involved our neurosurgery team who very promptly had done a ventriculoperitoneal diversion procedure. Now, I have made this cartoon-like thing up and down just to show that how a patient also goes up and down when in the ward and how alert one needs to be. Now, post VP shunt procedure, she was extubated in 24 hours and then she just required by mask. However, what we noticed was that she was developing tachycardia. A repeat CBC was sent. Here it was showing anemia. Okay, so now we have picked up anemia, which could be related to the linezolid which the patient was on. So that linezolid was now withheld. Next slide, please. Okay, now that was one complication that she developed an adverse drug effect due to linezolid. Second, what she developed is the VP shunt, which is seen here beautifully. What she also developed was respiratory distress on post-op day 3, and repeat chest X-ray showed haziness in the left lower zone and left CP angle. Okay, so this was nothing but mucus plugging, and what was given to this patient was chest physiotherapy. Of course, she was being supported with oxygen. Okay, and
Dr. Reepa, can you just mention what was the hemoglobin at which linezolid was stopped? What was the HB at that time?
It was 7.6, madam.
Okay.
And as I had shown you, initially it was 11.
Okay, thank you.
Yeah. So I'll come back to this X-ray. So here we are seeing that there is haziness present. Okay. With chest physiotherapy and oxygen and change in postures, this X-ray also improved and she also improved. Now, because she was having anemia, tachycardia and respiratory distress, we decided to give her packed RBC transfusion. Okay, so she received one PCV transfusion also. So here at that point of time, the issues were, although she was extubated in 24 hours and parents were happy that, child is now extubated, now when can we go home? All these questions the parents, they start asking us. She still had a weak gag reflex. So she was only put on RT feed strictly. And she had hypertension, which had persisted. Okay, so even after VP shunt, we expect that the hypertension should go away, maximum within 24 to 48 hours, but it persisted. So we had to add one antihypertensive also. So clonidine was added. Next slide, please. And for the neuro rehabilitation, lymph physiotherapy, and for her weak gag, swallow therapy was started. So we have a specialized team of neuro rehabilitation. We have our physiotherapists, swallow therapists come and they assist the child, and RT feeds were continued. So hence there was rapid worsening of CNS TB with development of SIADH, hydrocephalus and bulbar palsy after initial transient improvement. This is not even the ADR of linezolid, just the TB itself had caused these complications. Next slide, please. So hence I would like to conclude that all of us need to keep a watch in CNS when we are dealing with CNS TB. We need to keep a watch for complications. We need to anticipate it. We need to keep a watch for developing hydrocephalus, hyponatremia, signs and symptoms of raised ICT, any focal neurological deficit, there's a vascular infarcts, and even cranial nerve palsies. With this, this ends my case summary. Now, I would like to hand over it to Ira madam.
So thank you, Reepa. I think that was a very excellent presentation. And we took this case basically from the point of view that we had all possible complications that were occurring in this child. We had a child who's got CNS TB, MD, pre-XDR, you've started the second line. And then the disease is still evolving. The disease is not under control. She develops SIADH, she develops hydrocephalus. She goes on to develop cranial nerve palsy. So we've had that whole gamut of things which we wanted to discuss about how only anti-TB treatment is not the end of the story in CNS TB. So can I have the slides, please, now? The same slides have to be continued further. Yeah, so now we'll have a little discussion about CNS TB and how do you manage that. Next slide. So if you look at extrapulmonary TB in children, CNS TB is almost 5 to 10%, and children less than 5 years are at the highest risk because of an immature immunity. And I remember one study which Dr. Urvashi was saying about the drugs and the pharmacokinetics. I had one center coming from International Center who were doing the drug levels in CSF of all these TB medications. And they wanted to come to our center as one of the center because they were not getting enough cases in rest of the world. So this CNS TB is a major problem in India, Africa, and Southeast Asia. And the mortality is very high, especially if you have stage 3 TBM. I think you would have a mortality of almost 70 to 90%. And morbidity is extremely high if they are not treated early. You have this child who's come to you almost in stage 3 TBM. You know, she's come with altered sensorium. So if you catch them early, you have a better chance of recovery. Next slide. Next slide, yeah. So how does the CNS TB, you have this child who's got a miliary TB, he's got mediastinal, he's got renal involvement, and now you have a TBM also. Basically, it's just seeding, hematogenous seeding from the lungs. And you have this reach focus, which we learned in our pathology. And whenever that focus ruptures, you can get meningitis, so you can get meningitis, or you get tuberculoma. Lots of times TBMs are associated with spinal TB, which you call a spot spine, and you could get encephalopathy. Now remember, in TBM, one complication that we've not discussed in this case is vasculitis, but it's very, very common, and it's affection of the lenticular striate arteries. Somebody had asked a question on why did we give aspirin in this child? TB is an evolving disease. By the time your anti-TB drugs start actually working, it would take around 2 or 3 months. By that time, the disease would still progress. You could still develop vasculitis. And we've had patients who've had stroke because of TB. They just come with hemiparesis. You don't want them to land up with those complications. So it's better to give them aspirin, not very high dose, 3 milligram per kg, just to prevent these vasculitic problems. Next slide. So this is the modified British Medical Research Council staging. You have stage 1, 2, and 3. Remember, stage 1 is just fever and headache, and you're not going to get any signs neurologically. Stage 2, they'll come with photophobia, vomiting, lethargy. There'll be meningeal signs. There'll be seizures. Stage 3 is when they are comatose or encephalopathy. This child had come with altered sensorium, and there'll be posturing. There'll be focal neurological deficits that you'll pick up, decerebrate rigidity. So if your child comes in stage 3, you'll have a very high morbidity and mortality. The earlier you catch them, the better it is. Sometimes these patients will just come with regression, papilledema, hydrocephalus may be seen, especially keep in mind lateral rectus palsy. That is a sign of raised ICT. Keep in mind a facial palsy. So these are the other things that you will see in TBM. Next slide. In the CSF, somebody had asked a question, do we do an ADA? We don't do an ADA in children because it's not yet standardized. So we look at lymphocytic predominance, we look at elevated proteins, we look at low sugars, we look at gene expert. Either you could do an expert or you can do an ultra, and look for MTB and rifampicin resistance. But you also look at other sites, because most of the times you will not pick up on CSF, then you look at other sites. Like in this child, we didn't pick up on GL, but we picked up on the CSF. So look at other sites. Don't just stop at one. If you didn't get anything positive, look at other sites where you could do a gene expert. Next slide. Now, among the imaging, why did we do an imaging first and not a CSF? Whenever you have raised ICT in TBM, always do an imaging first. Once you have done an imaging and you have done an ophthal examination, you found there's no papilledema, your raised ICT is under control, then go ahead with a guarded LP. So don't straight on jump to a CSF in these patients, otherwise you may cause coning. So an MRI is always preferred over the CT because you could do an MRS at the same time. And MRS, if you have tuberculomas, you could look at lipid peaks. So you can rule out other ring enhancing lesions like neurocysticercosis and all that. If you have lipid peaks on your MRS spectroscopy, you can differentiate a tuberculoma from that. But most of the features on neuroimaging, you'll see basal exudates, you will see hydrocephalus, infarcts, you will see tuberculomas. Next slide. Other tests, always in extrapulmonary TB, don't ever forget to do a chest X-ray because 50% of your CNS TB will have a pulmonary involvement. So keep that in mind. So always do other, like how we did in our child, we had a renal involvement, we had a mediastinal, we had a pulmonary. There are other tests that are now being done on experimental basis, like you have a LAM assay, which can be done on a CSF. There is not much pediatric data on this. You have a next generation sequencing. You have other multiplex PCRs that are available, but this is not routinely done because I think we are pretty happy with our nucleic acid amplification test. Next slide. Now, if we look at treatment of drug-sensitive CNS TB, Dr. Urvashi did mention about newer regimens, especially with WHO now recommending ethionamide for drug-sensitive TB. We still stick to our straight guidelines of HRZE, and you give continuation phase for next 10 months. So you're giving totally 1 year, except that, remember, rifampicin hardly penetrates the CNS with the current dose that we are using. And you may have to increase it up to 20 milligram per kg per day in CNS TB for a better CSF penetration. So keep that in mind. Next slide. Now, I wanted to highlight on this. Sometimes you may have to give a regimen that is tailor-made. You may be able to give a standardized regimen. So a tailor-made regimen is something that you will have to consider. Among all the drugs which are first line, rifampicin with the current dosing will not penetrate. You will have to give higher dose. Ethambutol has a very poor CNS penetration. So it's just basically like an add-on drug. It doesn't really work for TBM. And that's why the South African data came on giving HRZ with ethionamide. Currently, we don't have data on the use of ethionamide, though we've published one study and it's accepted. It's not yet come out. It's advanced access available on the use of ethionamide in these patients. One thing I would tell you, before starting ethambutol in all these patients, always get an ophthal assessment done. You may get optic neuritis in these patients. You may have papilledema. Try and avoid ethambutol in these patients because of the optic nerve involvement. Then you may have to give an alternative drug. And if you're going in an alternative drug, ethionamide may not be a bad choice because it's got a good CNS penetration. Next slide. Among the second line drugs, we predominantly use bedaquiline, but bedaquiline CSF penetration is pretty poor. And we have very limited data on its efficacy in TBM. Same for delaminid. There is not much evidence of use of delaminid in CNS TB. Among the other second-line drugs that have got a good CNS penetration, all your fluoroquinolones, linezolid, cycloserine, and the best is ethionamide. So these are the drugs that you keep in mind. So sometimes you may have to give a tailor-made regimen, know which drugs are going to penetrate into your CNS. Next slide. So TB treatment is not only anti-TB. There's a lot about adjuvant therapy in TBM. So you need to decrease the inflammation. You need to get that cerebral edema or raised ICT under control. We have to improve the drug penetration and the survival. And we have to prevent the neurological sequelae like hydrocephalus and infarcts. Next slide. Role of steroids. I think the Cochrane analysis has given it very clearly that you definitely give steroids for pericardial effusion. You definitely give steroids for CNS TB, and you may give it for miliary TB. So steroids help to decrease the cerebral edema. It helps to decrease the inflammation that the child is going to land up with. Initially, you would give it as intravenous dexamethasone for 5 days, and then you may shift to oral dexamethasone or oral prednisolone. I know North India prefers oral dexamethasone. In Mumbai, we prefer oral prednisolone. It varies from center to center. So when you give steroids, you give it over 1 month, proper dosing, and then you taper over the next 6 to 8 weeks. But remember, sometimes these inflammation may go on for a little longer time, especially with paradoxical reactions coming in. That is what you call as iris. Or you could get something like tuberculomas that may be there. You may have to adjust your steroids based on the clinical picture. Next slide. Now, there have been instances, why I have brought up thalidomide is there are instances where you have these huge tuberculomas that are just not coming under control with steroids, or the child is developing cataracts with steroids or getting hypertension with steroids. And you may have to consider other TNF alpha blockers to control these granulomatous inflammation. And thalidomide is one of the other drugs that has been used. Before you start using thalidomide, remember it's a teratogenic agent. You should not use it in females who are adolescent age group because there is a risk of fetal limb hypoplasia. So don't use it in them. Be very careful when you're using thalidomide in patients with steroid resistant tuberculomas. Next slide. Somebody had asked about aspirin. As I said, it reduces the risk of stroke. So it's better to give aspirin. You may give it for the initial 1 to 3 months. And then once the TB disease comes under control, you may stop the aspirin. Next slide. Now, prognosis, as I said, depends on the stage. If you've diagnosed them early and started them treatment early, is stage 1, they have a good recovery, but stage 3 is bad morbidity and mortality. And if they survive as predominantly stage 3 would be bedridden. They would be still mentally subnormal. There would be cognitive effects. There would be hydrocephalus, hemiparesis, visual and hearing loss. So they are like a burden to their parents because the parents have to take care of them like a bedridden child. And if you have drug-resistant TB, then the outcomes are even worse. Next slide. So complications in pediatric CNS TB that one has to keep in mind, hydrocephalus can come as early within 1 week of the disease process. That's what we saw in our child, very early hydrocephalus. It can come as late as 9 months after starting treatment. So keep a watch. It's not something that you can just say, oh, it's not come now for 2 months, it won't come. It can come later also. Hyponatremia is another problem. You have to differentiate between cerebral salt wasting and you have to differentiate between SIADH. Stroke and infarct, so aspirin is a major thing that you have to give. There may be optic atrophy, that's what I said, that be very careful of using ethambutol in these patients. Cranial nerve palsies, in our child, we had gag reflex that was absent. You may get a facial nerve, you get a lateral rectus palsy. Seizures may be because of the TB itself, maybe because of encephalopathy, maybe because of electrolyte imbalance. Paradoxical tuberculomas may develop, neurocognitive developmental delay will be there. So these are the various complications in pediatric CNS TB. Next slide. Now, hydrocephalus is the most common complication. Almost 80% of your children with TBM will get it. And it's basically caused by basal exudate. So it's more of a communicating hydrocephalus. Leads to raised ICT, visual loss. And you have to identify it very strongly. What I tell my fellows is whenever you are suspecting hydrocephalus, child is bedridden, you won't come to know. Look at the lower limb spasticity. The moment you start getting lower limb spasticity, that means your pyramidal tract, your leg fibers are getting affected, and that's closest to the ventricle. So that tells you a hydrocephalus is developing because once you get a ventricular dilatation, the leg fibers are the first thing to get affected. So if you get lower limb spasticity coming up, think of hydrocephalus, get an imaging done immediately. And you may have to do a shunt surgery very soon. Next slide. Hyponatremia, very common, almost 60 to 80% which we see. One is SIADH, that is because of hypothalamic inflammation, that is increase in the antidiuretic hormone and water retention. And that's why you have to give fluid restriction. Whereas cerebral salt wasting is because of renal losses and hyponatremia. And both will cause central pontine myelinolysis, coma, seizures. So you have to identify between the two. Next slide. How do you identify SIADH? The patients will be euvolumic. Cerebral salt wasting, they will be hypovolumic. You look at urinary sodium. In cerebral salt wasting, the urinary sodium will be very, very high. And you look at the urine output. Again, in cerebral salt wasting, the urine output will be very high. With SIADH, the treatment will be fluid restriction. With cerebral salt wasting, the treatment will be giving sodium supplements and you have to give fludrocortisone. Next slide. So again, I'm just repeating this SIADH and CSW. So the treatment remains the same, but just keep that in mind that don't increase the sodium more than 10 milliequivalents in a day. Otherwise, if you do a very rapid correction of sodium, you will end up with a central pontine myelinolysis and you may lose the child. So if you have very severe sodium less than 120, give 3% NaCl and try and maintain the sodium, get it up to 10 milliequivalents more in a day, slowly and gradually. Next slide. Stroke and cerebral infarction is very, very common, and please don't forget to give aspirin. Next slide. So visual impairment, we've had almost in so many patients, we've had 3 patients who are completely blind after TBM. And the reason mostly is optic neuritis. So whenever you're using linezolid in these patients, be very careful. Again, 2 drugs that you have to be careful in TBMs. One is ethambutol and second is linezolid. So due to raised ICT, you could get papilledema, hydrocephalus causing, or optic neuritis itself. And it can be irreversible blindness. So keep on doing the fundus examination regularly in these patients. Next slide. Cranial nerve palsies, you predominantly get the 7th nerve, but you can also get the 6th nerve. Rarely you may get ptosis. All is because of basal exudates and inflammation in hydrocephalus. So keep a watch on the cranial nerves, and that again tells you that the TB is not coming under control. Next slide. So this is my key message, that you have to get early diagnosis, treat the TB quickly with steroids. You have to give drugs that penetrate the CNS. These drugs will be required for a longer time. You have to manage complications like hydrocephalus, infarcts and seizures, and hyponatremia, and monitor them for neurodevelopmental outcome in the long term. Next slide. Thank you very much.
Thank you, ma'am. Thank you, Dr. Deepa, Dr. Ira, for this case with multiple lessons. I would now invite questions from the audience. If you have any questions, any doubts, we can discuss them now.
I have one query.
Yes.
When the patient came, this was first contact with the patient to your hospital, or patient has shown somewhere else also? He has attended other facility also.
No, the child did go because there's fever for a month. So the child has been going to doctor. Nobody really picked up anything.
Okay. Thank you. Thank you.
Madam, hello.
Yes.
Madam, I have some queries regarding as a clinician and as a public health specialist.
Yeah.
And we had a training of PPT in AIMS. They of the opinion that as a public health specialist, they said the side effects of ethambutol are quite low, and so we can give in community. So what we got the lesson is that while we are giving this ethambutol, we should also see the status of this optic palsies. We can also do the OCTs also at times or not. My concern, madam.
Yeah, say ethambutol, at the moment the guidelines don't recommend you ethionomide, though WHO has come out with a new regimen. So at the moment the guidelines don't mention ethionomide. We still are
I'm not talking about ethionomide, I'm talking about ethambutol.
Yeah, so the guidelines still mention ethambutol.
Yeah.
But ethambutol is predominantly going to be color blindness.
Exactly.
Which a child is not going to be able to tell you very clearly. So you have to be, what we do is the moment we get papilledema or we get some evidence of optic neuritis, we don't give ethambutol in these patients. But you could give if these 2 things are not there.
So, madam, how can we diagnose this ethambutol, say in a tertiary care hospital? I don't think that this OCT is available in every tertiary care centers, madam.
Yeah, so there are only 2 things that you'll have to do. Your ophthalmologist will have to do eye examination every month. Look for papilledema, look for optic neuritis. That's the only way that you'll be able to pick up.
Thank you. And madam, what is the role of this levocitizine? Because patient had at that time.
Whenever you have a child who's come with encephalopathy, whenever you have a child who's undergone a BP shunt, In these patients, you will have to give levetiracetam for some time, maybe 3 months, and then taper it off. Because they are very prone to get seizures.
But we usually give this for 3 years.
No, only if the child has had epilepsy. So if there has been a seizure episode, then you will give it longer. There has not been a seizure episode. The child has undergone a surgery like VP shunt, then 3 months is enough.
Okay, thank you.
I had one. Ma'am, are you using aspirin routinely for all patients?
Yes. Yes.
This is not in the current NTEP guidelines as of now.
Yes, but there is enough data to say that it helps to prevent a stroke.
Yes, the data is emerging, but as of now, I think it is for the audience to know that the standard of care as of now, as per NTP, aspirin is not being given.
Yeah.
Ma'am, as again, ethambutol, as you said, again, both WHO as well as NTP, they still say it is safe as of now. And if you look at the guidelines, they still suggest ethambutol as a part of a standard.
It is safe. I'm not saying it's not safe. How effective it is, we do not know.
Yes, ma'am. So one point that I wish to raise is that in TBM, it's the most severe form of the disease. There is life and there is a quality of life.
Right.
So when we are treating such patients, we should not lose onto that precious time, because there are centers where MRS, even ophthalmological evaluation at times, radiology they will not be immediately available.
Right.
The message is that if you have a doubt, you should start treatment and keep on working, because getting a microbiological diagnosis in TBM is not the same as getting a microbiological diagnosis.
You will have to be very, very quick in getting a diagnosis. So the whole idea of presenting this case was that you had a diagnosis in next 2 or 3 days. Though the child was started on ceftriaxone on the first day itself.
Yes.
We got a diagnosis by day 2 that this child's gene expert came positive. And we had a diagnosis of pre-XDR TB by day 3 when we got an XDR panel done. So you will have to be very quick. The problem is in a city like Mumbai, where your MDR is almost 10% of all kinds of TB, and you're going to start first line based on clinical or radiological diagnosis, you may land up missing up drug-resistant TB. So strive very hard to get a microbiological diagnosis.
So if I put it another way, suppose this child comes with a subacute onset neurological illness, where you have a lymph node, where you have a miliary TB, where you have features of raised ICT. Other than TBM, what will be a more plausible diagnosis going by the epidemiology? And this clinical symptom complex, to say that it will be not TBM will be very hard. Of course, the point that I still accept is that if you have any epidemiological indicator of a drug-resistant kind of a TB, probably you should be aware, you should be guarded about that. But this particular case was, I think, one of the very. If I get such a case, I'll say, okay, I don't have a doubt. At least we have a history which is going for 1 month. You have a radiology which is saying.
This case was presented from the point of view of the complications of TBM. You have a child who's developed SIADH, you have a child who develops hydrocephalus. You have one imaging, you don't have hydrocephalus. In the next 4 days, the child develops hydrocephalus.
Yes.
So keep those things in mind.
And lastly, one more point that I wanted to make is that you have shown that prognosis that in the stage 1, 90% of them will not have any deficit. In stage 3, 30 to 40%. The other way to look at it is that mortality in stage 1 is 5%, and in stage 3, it goes to 30 to 50%. So the point that I'm trying to make is that these 48 to 72 hours can make a huge difference in terms of mortality. So if suppose you do not, if there are centers which will not have access to such radiology.
So in centers which don't have access, you can straight away start the first line based on the radiological diagnosis.
This is what I wanted to say, because
the moment you get more workup, you can immediately shift to the second line.
You can always downgrade, change, think of a ethambutol or without a.
So don't waste time and not start.
This is this because the bigger audience will be such that probably.
Okay.
Thank you so much. Thank you.
Yeah.
I would like to add a few things, regarding the discussion, which very interesting discussion regarding ethambutol. Dr. Kamal highlighted that we are still using ethambutol. Yes, we are still using ethambutol, and WHO also recommends ethambutol, provided you give it within the therapeutic range, that is 15 to 25 milligram per kilogram body weight. Please never overshoot 25. Because if you enough data and enough meta-analysis has emerged that the toxicity of ethambutol that is seen once the therapeutic range is you're giving more than 25 milligram per kilogram. So if you remain in the range of 15 to 25, the chances of ethambutol toxicity are very low. Now, the other thing I would like to say over here is regarding, why we have not been able to adopt the 6-month regimen, which has been recommended by the WHO. That is 6 months of rifampicin, INH, pyrazinamide, and ethambutol replaced by ethanamide. So, this study was conducted in South Africa, on the basis of which the WHO came out with these recommendations. So during the meeting of the WHO, I raised this point that we are giving drugs. That is, we are giving INH and also we are giving ethanamide. When we do not, and this is recommended for the DSTB, TBM. The recommendation says that for DSTB, TBM, you are safe to use 6 months of this regimen, that is with ethanamide. But in our country, we have baseline high IMH resistance. So that was my concern during our WHO meeting, because if we do not know the IMH status, IMH resistance status, there are two genes, that is CAT-G and INHA. Now, in INHA gene, you can give high dose of INH, but there is ethanamide resistance. While in CAT-G, it's the other way around. So, without knowing the baseline INH resistance, as in this case, when the expert XDR was done, it showed that H and FQ resistance. So, I have a question for Dr. Ira. Did you also send it for the MGIT investigation? Because that is important. You're giving ethanamide, and we know that you had to stop linezolid because of anemia. One thing which needs to be taken care of is to know the INH resistance once you are using these drugs. That is my concern, and I would say that this case has given, Dr. Ira has given very good clinical insights into the case, that suppose you are working in a periphery and you do not know how to diagnose, whether hydrocephalus is developing or not. So that is a very good clinical tip, which I would say is that if you start to notice that the tone of the lower limbs is increasing, so that could be a very subtle sign that hydrocephalus is developing, because as she said, the lower limb fibers are close to the ventricles, the lateral ventricles. So these were the concerns, and regarding the complications, hydrocephalus is a complication which develops quite frequently whenever you have any meningitis, and to differentiate between hotly treated bacterial meningitis and TBM can be a problem in the clinical scenarios, most of them. While in this case, they were lucky because they were able to pick up the organism. So that's another very big lesson to learn, is that always try to fish out the organism from the easily accessible sites, like pulmonary, sputum, or alternative specimens, and even palpate the cervical lymph nodes, because you can get a sample from the fine needle aspiration and attempt a CSF only after you have ruled out, fundus examination, or if at least you are lucky enough that you have a radiology available. So with these things, I would like to say a very interesting case, and she's already highlighted the differences between syndrome of inappropriate secretion of ADH and steroid wasting syndrome. And the basic, both will have hyponatremia clinically. But how to differentiate, your blood pressure? If a blood pressure is normotensive or slightly raised, as in this case, there was hypertension, so it goes in favor of syndrome of inappropriate secretion of ADH. While in steroid wasting, there will be, the patient will be in shock or the BP will be on the lower side. So very interesting case, Dr. Ira and your team. I must compliment. Lot of learning lesson and very good discussion. So any questions we have?
I have one. Sangeeta, there was nice feedback from your end, and you are really doing a lot of efforts in getting these clinics in place. Only one thing about ethionamide that I wanted to answer is, in this child we had an XDR panel, and in the XDR panel you get both INH-A and CAT-G. So you come to know about ethionamide there and there.
So in this case you had H and FQ resistance.
Yes. Which
gene involved?
Pardon?
Which gene was involved, INH-A or CAT-G, for the information of the house?
So it was a CAT-G gene.
Yeah. So that is the reason she gave ethanamide. So if you have CAT-G mutation, then you can add ethanamide, and ethanamide has got a very good CNS penetration.
I have one question, ma'am, regarding the hydrocephalus in the TBM patients or the ventricular dilatation. Which you prefer, 3% mannitol or 3% NaCl or mannitol? Actually, in this case, you give specific 3% NaCl. So I just want to know, okay, generally we also give mannitol. So is there
mannitol we don't usually give till your sodium is okay. So usually in TBMs, we try to maintain the sodium around 140. We don't even like it at around 135. So if your sodium is around 140, and you know that the cerebral edema is not because of hydrocephalus, but because of the cytotoxic edema, then you may give one shot of mannitol and see the response, provided your blood pressure is normal. If you are having low BP, low sodium, don't give mannitol. Then only use 3% NaCl. So that is one thing about mannitol. And don't use it routinely 3 times a day. Just give it one shot and see whether there's a clinical improvement. If there's no clinical improvement, your mannitol is not going to work.
And 3% NaCl for how long, ma'am?
So 3% NaCl is based again on your electrolytes. You maintain your sodium around 140, maximum 145. Don't go beyond that. And your raised ICT. If your raised ICT is coming down, you can start tapering with the 3%.
Any questions, anybody?
Dr. Sangeeta, I have put down one query in the chat box.
Okay, sir.
Madam, I have shared one question.
Yes.
There are doctors also who join from the periphery. So, what are the predictors or the risk factors for a child being late diagnosis turning to be TB meningitis? There are a lot of children who get TB exposure who are at high risk of becoming TB meningitis. And what could be the earliest symptoms that could be picked up in a periphery where the delay can be prevented? This could be a helpful experience for all people from working in the periphery.
Can you please repeat your question?
If you're saying that in the periphery, what are the risk factors to have TBM?
TBM, yes.
So, Dr. Ira, would you like to answer?
So the moment you have a child who is malnourished, the moment a child comes with fever for a long time and just headache, you may not even have any other symptoms, then think of TB. There is a history of TB in the family, then think of TB. These are the things that you will have to keep in mind in these patients. So this will be your first idea that tells you that there's something wrong with the CNS and most likely TB.
Okay, thank you.
There is one more, if you can, I can make one comment. A lot of TBMs that we are seeing as of now, I don't know, they're raining TBMs as if in my HDU, I think
in this month of May, we had all patients in the TB isolation who had CNS TB.
So there is something which has happened. I don't know what. And one peculiar thing about this is they have contacts in whom the children have not received chemoprophylaxis.
Yes.
All of them had contacts, but the contacts were not questioned and evaluated, and all these children were not have not received chemoprophylaxis. This is probably one of the which I could identify as one of the things. But as ma'am said, TBM stage 1 is very difficult to diagnose. It can mix up with a lot of things, but a persistent fever and headache, it is very unlikely that somebody has TB meningitis developing but no headache. That's a bit odd. But otherwise, rest all can mix up with anything.
There's one question, Dr. Ira.
Dr. Ashwini wants to know that in this case, though we were able to get evidence for MDR because we got a gene expert done, suppose the CSF had not shown MTB, then how to exclude MDR?
You would have to start first line in such a scenario where you don't have a diagnosis of MDR and see the response to therapy. You may have to try and get cultures, like suppose in this child CSF would not have picked up, then you would have probably to go to BAL, bronchoalveolar lavage. You may have to get a urine gene expert done, but somewhere you would have to get a microbiological diagnosis. In the meantime, you would have started first line and not waited. But you would have tried very hard to get it from other sources.
I hope this answers
accessible sites, as I said. We have diagnosed MDR from cervical lymphadenopathy, not test positive. So always remember the easily accessible sites. That is a respiratory specimen, if the child is able to cough up sputum, otherwise alternative specimen.
Madam, you have mentioned that in case when this is not given, sputum is not available, we can take from BAL. Madam, yes. But in this case, can BAL be feasible in a child with a tubercle meningitis?
The moment you have this child intubated for a
they may say the pulmonologist will say it is not recommended.
Yes. No, the moment you have a child intubated for a BP shunt, you could have straight away taken the ET secretions. Sometimes we also do stool gene expert, though it's not recommended in the program, but we've got patients where we've done a stool gene expert and we picked it up. So it depends. You have to get a specimen from where you have to keep on trying.
Okay, thank you.
Any other question?
Any other questions from the audience?
Somebody has asked how often you get combined TBM and pyogenic infections. You don't get it combined. You may get a pyogenic BP shunt infection after the surgery is done, but not at the onset.
Hello, how long do you recommend your aspirin for generally?
I think I've already answered that. If you don't have vasculitis, you can give it for 3 months and then stop it.
Thank you, ma'am.
So, Dr. Urvashi, any final comments you'd like to add? Dr. Urvashi?
So I think we had a very fruitful discussion, and I'm confident it was useful for all of us, all those who have joined us today. And I'll reiterate what I said earlier, that we need to look for a regimen that works better than what we are currently using. So, of course, Dr. Ira also and the other expert, Dr. Singhal, everybody talked about what is available and has been tested. I am suggesting look for options which will work synergistically, get good levels in the CSF and other extrapulmonary sites, because you see, if you want to do such an exercise, you need to know the pharmacokinetics and pharmacodynamics of the drug, the compartmental concentration of the drug, which compartments the drug can reach and which it cannot. So ideally speaking, we should have, clearly tailored regimen, and not just empirical pulmonary TB regimen, which is then extended as per the decisions of, say the clinician decides that the patient has not responded and you can extend it. For example, bone TB, tendency is to just extend it further without getting a grasp of the in vivo picture as to the bacteria are going to be actually exposed to subtherapeutic levels. So what are we doing? We are enhancing BRTB. So that is the accepted dogma. You give subtherapeutic concentration and the resistant bacteria will multiply. So we are enhancing by not using the right regimen. So that is my earnest request and suggestion to all the TB experts who deal with the extrapulmonary TB in a big way. And, the program plans to have a consortium of such experts who can deliberate this further and come up with a combination that we all agree works scientifically better than the available regimen. So, with these words, thank you for the wonderful deliberations, and thank you, Dr. Sangeeta and NITRD, Director of NITRD, for hosting this. And thank you all for joining.
Dr. Urvashi, regarding the ethionamide that you mentioned about the newer regimen for CNS TB, especially drug sensitive, we've done a retrospective analysis on our patients in whom we ethionamide, and that paper's got a publication in Lung, India. The moment I have advance access to that paper, I will send you a link for that.
Dr. Ira, I think there was Dr. Sangeeta was adding.
The problem is that we have high baseline INH resistance.
Yeah.
So why we are not able to accept this regimen in our country.
Yeah.
And there is certain, because we are not doing INH resistance for each and every patient of DSTB where we start. And when I questioned WHO team, even they were in agreement, because I do not know about Mumbai, but to roll out this regimen, I think Dr. Urvashi will have to take a call, and I'm not for it.
Okay.
Because, yeah.
All right.
Any other questions?
Yeah, I just wanted to make this point. We need to think out of the box. We need to think with science. So all of us have to have a better knowledge of the PK/PD of the different drugs. We have to actually dig deeper into what drug levels is every drug reaching in different compartments, whether a drug has adequate level in the bones, whether it is penetrating the blood-brain barrier and reaching inadequate levels to the CSF, and what combination would work, depending on which drug acts on which type of bacteria. I have a colleague with me from Netherlands who, Dr. Richard Anthony, he's with me right now, who actually is questioning why we know pyrazinamide is for persisters. Why is it not used at a time when persisters would be most, that is the end of treatment? So my point to all of you is read more about the pharmacology of the drug, the PK/PD of the drug, and make suggestions which may not have been thought of earlier as the right combination regimen for the extrapulmonary sites. So with those words, thank you.
Thank you very much, ma'am, for your remark. Thank you. Is there any question? Any question? So there is no question. So now I conclude the session. Thank you, Dr. Deepa and Dr. Ira ma'am, for this case, which are multiple lessons. This is a very important to identify CNS TB early so that we can reduce the mortality and morbidity both. We should always try to find out the microbiologically confirmation, whichever the site from where we can find out the bacteria, and after that particular we have to start the drug regimen according to that. So for the concluding remark, I invite Dr. Ashok Bharadwaj sir, Chairman, NTF, for the concluding remark.
Thank you, sir. Thank you. So first of all, I must compliment Deepa Agarwal for excellently presenting this case, this rare case. So then the Ira. So thank you, Ira, for explaining in detail the epidemiology and management of CNS TB. So here I want to say that this information should be percolated to the down, because most of our pediatrician colleagues, they are not aware of these guidelines. That is why Sangeeta always says that more people should join, more people should join. So, of course, more than 200 people joined today. But I have one concern. I want to reiterate it, the concern raised by Dr. Singhal. So, of course, chemoprophylaxis is very, very important for children, as well as TB preventive treatment is very, very important for other groups. So we must judiciously follow this PPT. Otherwise, we will not able to prevent new infection in the children as well as in the adults. So thank you very much. Thank you, Sangeeta madam, for giving me a chance. Thank you very much.
Sir, thank you so much. Your words are always a source of encouragement. And we look upon you. Again, I am requesting you, sir, with your help, we want the involvement of more and more medical colleges. From such interesting cases. The next session, which is going to be on 15th of July, and AIMS Raipur is going to be the presenting team. So, sir, what I want medical colleges, and for that, I am requesting you, Dr. Ashok Bhadar, to help us, so that we have more of UH and more pediatrician colleagues, PGs, undergraduates, and faculty. They are able to, benefit from, because the basic purpose is in dissemination of knowledge, and the more we learn from each other, the better it is, and that is the precise reason that we are pushing in the pediatric TB eco. Thank you all for joining in and forwarding to Dr. Alok for the final remarks.
Thank you everyone for joining today. And as ma'am told, the next pediatric TB Eco Clinic is on 15th of July. So we will see you all soon. Thank you very much. Thank you.